Okay. And it is a chronic inflammatory disease of the airways. And what happens as a result of this chronicity of the inflammation, there's going to be hyperresponsiveness, edema of the mucous membranes, and of course, mucus production. So those are the characteristics of asthma. And so let's begin with the pathophysiology. So the underlying pathophysiology in asthma is going to be an airway inflammation that eventually leads to narrowing of the airways. So what precipitates this particular reaction by the airways? Well, it begins with an inhalation of an irritant, like, for example, cold air or an allergen like pollen, which then, because of bronchial hypersensitivity, leads to airway inflammation and an increase in mucus production. So there are several stages as far as asthma is concerned, and the early phase is going to be initiated by what we call IgE antibodies. Now, there are several antibodies in the body, and they're usually identified by the prefix Ig. So when you see Ig, for example, that's an immunoglobulin or an antibody, and there are several of them, but IgE is an antibody that is going to be sensitized, and they're released by plasma cells. And when the mast cells are activated, it releases several chemicals, and these chemicals are called mediators. So the substances that are released from the mast cells include histamine, for example. This is a mediator. Another one is prostaglandins, and the other one is leukotrienes, which we will be talking about later on. These cells, in turn, contract the smooth muscle and therefore cause it to tighten and therefore proceed with a characteristic symptom of asthma. The second phase of asthma is perpetuation. Now, the chemicals that I talked about, like histamine, prostaglandins, and leukotrienes, will perpetuate the inflammatory response. So what happens whenever you have inflammation? You're going to have an increase in blood flow, and as a result of that, there's going to be attraction of white blood cells to the area, and eventually, therefore, bronchoconstriction. So the bronchoconstriction that occurs in asthma are due to allergens and results from the release of mediators from mast cells that I have talked about. And the last phase is going to be progression. As asthma becomes more persistent, the inflammation progresses and other factors may be involved in the limitation of the airway. So if we are to look at the pathophysiology of asthma, there's a trigger. And if this were the airway, what happens is the mast cells are going to produce some substances, and these are inflammatory substances, and they're going to be called mediators. And the most common mediators that are going to be present in asthma is going to be histamine and leukotriene. And the other one is prostaglandins. Okay, so whenever there is going to be these mediators release, it's going to cause narrowing of the airways. Why is there going to be narrowing of the airways? Well, because of inflammation around this area. So if you inflame the lining of this area, and my pen doesn't seem to cooperate, if you are going to have inflammation of this area, then eventually there's going to be narrowing of the airways. Now, the inflammation actually causes a leakage of fluid from the blood vessels, and that is why there's also going to be a lot of mucus that's going to be produced. So there's going to be thick mucus as well as swelling of the membranes, and at the same time, also smooth muscle contraction. So all these will lead to the narrowing of the airway. So there are recognized factors as far as predisposition to asthma. And the first one is genetic predisposition, specifically a personal or family history of allergy. And usually in children, for example, you might see eczema or hay fever, as well as asthma. All these are going to be factors that increases the risk for the development of asthma. And then, of course, there's going to be environmental factors. We all know that people can develop asthma after exposure to things that irritate the airways. So this would include allergens, for example, toxins and fumes, and either secondhand or third-hand smoke. These particularly are going to be very harmful to infants and young children whose immune systems haven't finished developing. Environmental factors would also include prematurity. So premature infants are going to be predisposed to the development of asthma, particularly if the parents smoke. And respiratory infections, certain respiratory infections such as RSV or respiratory syncytial virus can damage young children's lungs and predispose them also to the development of asthma. Now, there are some triggers like a viral respiratory infection or exercise. And the reason why exercise usually causes asthma is because when we exercise, so we open our mouth and we breathe through our mouth. And when you breathe through your mouth, you're breathing in cold air. So normally when we breathe through our nose, it's warmed by the structures of the nose, and bypassing that usually could therefore precipitate an asthmatic attack. In addition to that, when you exercise and when you open your mouth, there's drying of the airways due to the cold air that is going to trigger, therefore, an inflammatory response. So that has a lot of bearing to the teachings that you're going to do whenever you are talking about exercise for patients who have asthma. Now, certain drugs also are going to be triggers for the development of asthma. In particular, non-steroidal anti-inflammatory drugs, as well as beta blockers and aspirin, are going to be medications that can precipitate or trigger an asthmatic attack. And beta blockers obviously are going to be triggers because it interferes with the bronchodilatory effect of catecholamines. So that's the reason why beta blockers, non-steroidals, and aspirin has to be avoided in patients with asthma. Okay, let's go to our first poll, and let's see. I'm going to launch it. Can you just hold on one moment? I just need to respond to the door. All right, thank you very much. Yes, you all got that correctly. Mast cells is the correct response. And so let's go to the next one. Okay, so let's apply a little bit of test-taking strategy over here. It says obstruction of the airway in the patient with asthma is caused by all of the following except. So whenever you get questions like this, turn it into a true or false. Okay, so in asthma, would you have thick mucus? You remember in my illustration, I said that there's going to be an abundance of mucus because of the inflammation. So the answer to this is yes. So it could not be the correct response. How about letter B, swelling of the bronchial membranes? Yes, because of the mediators being released like prostaglandin, histamine, and leukotriene, they're all going to cause swelling of the bronchial membranes. And therefore, the answer to this is true again. So it could not be a correct response. Letter C, is there destruction of the alveolar wall? Well, this describes the pathology of COPD or emphysema, I should say, not that of asthma. Okay, so there is not a destruction of the alveolar walls in asthma. That is going to be a finding that is going to be present in emphysema. So in the pathology of emphysema, the problems are going to be in the acinar units. The acinar units are where the alveoli are located. And what usually happens, and I will enlarge these, if this were the alveoli, what's going to happen in COPD is there's eventually going to be destruction of these things over here. And therefore, instead of having 4 balloons, you're only going to have 1 balloon. And that is the reason why in patients with emphysema, they are going to have air trapping because of the destruction of the alveolar wall. So this is the correct response. And then, of course, letter D, bronchoconstriction or contraction of the muscles surrounding the bronchi are going to be findings in patients with asthma. Okay, let's go now to the clinical manifestations of asthma. So there are 3 the triad symptoms of asthma. It's called cough, dyspnea, and wheezing. So this is going to be the most common symptoms of asthma. Now, as far as the cough is concerned, there are instances that cough is the only symptom. And dyspnea might be characterized or described by patients as just tightness, and it leads to dyspnea. And lastly, the wheezing, there may be wheezing, and it is first on expiration and then possibly during inspiration as well. All right, so this is a common question in Nclex. When is the wheezing usually occurring in asthma? Well, it usually is going to be on expiration. Now, why is that? We need to understand why the wheezing is going to be much more intense during the expiratory phase. Okay, if this were the alveoli and the airway, and you are breathing in Breathing in is an active process. So it's almost like blowing a balloon. There is a force, and therefore it opens this airway with great pressure. Now, however, on expiration is a passive process. And therefore, as a result of the passive process that occurs with expiration, this airway, which is going to be tight as a result of inflammation, is going to now collapse. And therefore, it causes the wheezing. So again, it's an expiratory wheeze is the most common symptom, but possibly also as the disease or the attack progresses, you might have inspiratory wheezing as well. Now, when does asthma occur frequently, or the attacks? The attacks frequently occur at night or early in the morning. That is when the air is cold, and therefore that is when the attack usually is going to be much common. Now, there's going to be also efforts as far as expiration is concerned. It requires a prolonged expiratory effort. Again, it's because of the narrowing of the airways. The patient has to have more effort expended in expiring the air that is in the alveoli. And lastly, the occurrence of severe asthmatic attacks is what is known as status asthmaticus. Now, I also must add that there is exercise-induced asthma, and that could be another pattern. This is when maximal symptoms occur during exercise, and sometimes this is just a feeling of choking when the patient is having exercise. So all these are patterns as far as asthma is concerned. All right, let's go to another poll. Okay, so again, in answering this question, you're going to, because it's a negatively framed question, meaning to say that you need further education. You're looking for something wrong. So again, transform this question into a true or false. So the statement, my child might become restless if he is having trouble breathing, this is a true statement, isn't it? Anybody who is going to have trouble breathing, particularly if they cannot tell you that one of the manifestations of having breathing difficulties would be restlessness. Okay, so this is a true statement. I might hear my child wheeze during an asthma attack. This is also a true statement. I expect my child's peak expiratory flow to increase. Now, expiratory flow is the force that a patient will have, like in blowing a balloon. Will it increase or will it decrease? If a patient has an asthmatic attack, will they be able to blow a candle?
No.
No. Okay. So this is an erroneous thing. The force of expiration is going to be decreased in patients with asthma, right? And frequent coughing can be a sign of an asthmatic attack, and that is a true statement. So therefore, the correct response is letter C. Okay, so always use that strategy whenever you see a negative question means to say that you're looking for something that is in error. Okay? All right. So here's another one. How about the others? Okay, so let's go ahead and ask ourselves again, because this is a negative question. Does not occur. All right. Is there going to be chest tightness in asthma? And you remember I said that some people will just describe it as chest tightness. So this is a true statement. How about mucus plugging? You remember that there's going to be an increase in mucus production. So this is also going to be true. If a patient is in respiratory distress, will you have bradycardia or tachycardia? Well, obviously, because of the stress response, there's going to be tachycardia. So this is going to be the one that's going to be false, and therefore that's the answer. And wheezing is also true in patients with asthma. Okay? So I want you to always apply that particular strategy whenever you are answering questions that are negative in nature. All right, there are several complications associated with asthma, and they include status asthmaticus. This is when the airway obstruction is going to be so severe that it results in hypoxemia. And of course, if left untreated, asthma progresses to respiratory failure. And lastly, pneumonia is a common complication because mucus that pools in the lungs becomes infected and therefore can lead to the development of pneumonia. So let's take a look at the assessment and diagnostic findings as far as patients with asthma is concerned. Well, to determine the diagnosis of asthma, we must always look at the episodic symptoms of airway obstruction that are present. So it would also include taking a history, because we know that there's a genetic component of the disease. So asthma is a hereditary disease and can be possibly acquired by any member of the family who has asthma within their clan. And then, of course, we also look at the environmental factors. When the asthmatic attacks usually occur? Well, they occur usually with high pollen counts. So when would we have high pollen counts? During the spring and also during the fall. All right, other environmental factors would be the presence of mold, or maybe pets. If they have a pet, maybe pet dander, or sometimes climate changes and air pollution are usually factors that contribute to the development of the asthma. So what are some of the physical examination findings that you will see in asthma? And this is a very common Nclex question, the tripod position. And what's a tripod position? So if you put your hands on your knees and lean forward like this is what is known as a tripod position. And many times these patients who have respiratory difficulties will usually assume this position because it helps them breathe better. So that is a very telling finding. And the other thing is bilateral expiratory wheeze. And whenever you assess a patient with asthma and you do not hear anything, It is not your ears that is the problem. The problem is that there's no air going into the patient. So if you're having difficulty hearing lung sounds on a patient, that means to say that this is a dangerous situation. You must activate the rapid response team if that occurs. Also, on physical examination, you might also see signs of hypoxia. So what are the signs of hypoxia? Restlessness is the first finding as far as hypoxia is concerned. And of course, there's going to be a decrease in the mental state of the patient. So it includes, for example, progressively having an alteration in the mental status. And there is going to be signs of imminent arrest, meaning to say that if the patient is going to have mental status changes and bradycardia, and you cannot hear any lung sounds, this is an indication that the patient is ready to go into respiratory arrest. So that would be a signal for you to activate the rapid response team. All right, so what are some of the ways in which we diagnose asthma? Well, when we suspect asthma, the first step in diagnosis is conducting a pulmonary function test, also known as a PFT. And the most important measurement are going to be the forced vital capacity, which is the total volume of gas exhaled after a maximum expiration. So whenever you breathe out and you inhale, then this is going to be a measurement of your tidal volume. But your forced vital capacity is the gas that you exhale after a forced expiration. So when I take in a deep breath and I blow as much as I can and as long as I can, this is what's called the FVC. Okay, so that's the forced vital capacity. Now, how about this forced expiratory volume 1 or FEV1? So if I illustrate that, and let's say that this is the volume and this is the time. When you exhale, is your exhalation going to be maximized or highest at the beginning of your expiration or at the end of your expiration? And the answer to that is it's going to be at the first part of your expiration. So if I ask the patient to breathe out and I measure it, it's going to be like this, and then it gradually will go like this. So I ask you to take in a deep breath and then blow, and you blow very quickly, and it will go down and down and down right here. But the first second, if we take the volume during the first second, this is what is known as the FEV1. Understand? The forced expiratory volume at 1 second, or the FEV1, is going to be decreased in asthma. Okay, so the whole volume right here, the forced expiratory volume, as well as the FEV1, which means the expired volume at 1 second, are both going to be decreased in asthma. So those are the classic diagnostic measures that we're going to do whenever you are going to have a patient with asthma. All right, so the other thing is peak flow measures. When you have a spirometer, and this is going to be a crude measure of respiratory function, and you ask a patient to blow as fast as they can. This is what's called the peak expiratory flow rate. Whenever you have a patient who has asthma, you're going to compare it with their PFR when they are normal. So let's say that your peak flow measure is going to be without an attack 500. And now on a daily basis, I'm going to monitor your progress. And now you breathe 400. So this is going to be how many percent of your peak flow. How many percent is 400? Hello? Is this good or bad? All right. So take 70% of 500. 500 times 0.70. So your 70% is 350, which means to say that 400 is going to be good. But let's say now that your peak flow measure is only 200. This is going to be less than 70% of your predicted peak flow. And there is usually a nomogram to tell us what the normal peak flow pressure is according to age. So I could not tell you what normal is because it depends on your age and also it depends on your weight. But just to know that the way in which we measure the degree or the severity of an asthmatic attack is to measure the peak flow pressure. Okay? And so the goal is that we should always have 70% or more of our predicted peak flow measure. Okay? So this is going to help identify whether or not the patient is having respiratory distress. So in patients with asthma, we usually advise them to monitor their peak flow on a daily basis. Okay, so there is a important word over here, and it says early warning signs. Early warning signs. That is going to be a key word in this question, early. All right. Is easy fatigability with physical activity, is it a warning sign of an asthmatic attack? And yes, this is correct. How about a reduced peak flow meter reading? And this is also correct. And nighttime coughing is also correct. And cyanosis is a late sign. All right, so remember that cyanosis occurs when your hemoglobin is no longer saturated with oxygen. And therefore, this is going to be an advanced state of an asthmatic attack. So that would be an incorrect statement. And then, of course, wheezing with activity is going to be a correct response. So actually, C and E are going to be signs that the patient is having symptoms of an active asthmatic attack. Okay. And let's go to all right, so what are some of the assessment findings and diagnostic findings that we're going to use in the management and evaluation of patients with asthma? While pulse oximetry can be very useful in assessing the severity of an asthmatic attack or actually monitoring them for deterioration. However, we have to make sure that we understand that pulse oximetry is not going to always tell us about the oxygen state of the patient. Okay, when the pulse oximetry is going to be declined, this is going to be a late finding. And therefore, we still have to utilize other tests like ABGs, for example, in order to accurately determine the respiratory state of the patient. As far as laboratory tests are concerned, urea and electrolytes are always going to be important because they assess kidney function. And the reason why we would like to look at the kidney function is because we are going to use high doses of short-acting beta agonists as well as long-acting beta agonists. And one of the side effects of your medications is going to cause potassium shift, and therefore electrolytes are very, very important. The other thing is, of course, ECG, and ECG will reveal usually sinus tachycardia, and which could either be as a result of the asthma itself, or it could be a side effect of the drugs that we usually give to these patients. And it is obvious that we need chest X-ray in order to see if there is an underlying infection that would have precipitated the attack. And lastly, the spirometry, and which we had already talked about, the spirometry, which is going to be very, very important in measuring their peak expiratory flow. Okay, so let's go to the next one. Okay, so let's see the correct answer here. Which result would be most concerning for a patient experiencing an acute asthma exacerbation? All right, so let's just review. A normal pH is going to be 7.35 to 7.45. And a normal PCO2 is going to be 35 to 45. And the PO2 obviously is going to be 90 and above. All right. So if we take a look at this pH of 7.32, this is acidosis. And the CO2 of 50 is also acidosis, and the O2 is going to be normal. 7.40 is normal, and the CO2 of 34 is low, so this is alkalotic. And the PO2 seems to be okay. And of course, this one is normal. And the PCO2 is normal as well. So this is going to be okay. And the last one, this is normal. This one is normal. And this one is normal as well. So this is the one that is going to be problematic. We have respiratory acidosis. So the correct response is letter A. All right. Okay, so I don't know if I told you that if you wish to have a review of ABGs, on my YouTube channel, there is a very, very good, I feel like it's a very good series. It's three parts on how to interpret arterial blood gases. So I invite you to visit that site. Okay. All right, let's go to the next one. Okay, so let's take a look at this question. The pH is 7.28, so that's acidosis. That's a lot of acid. And PCO2 of 50 is acidosis. And a bicarb of 25 is normal. Okay, so bicarb is 22 to 26. So 25 is normal. So this is a non-compensated respiratory acidosis. Okay, so whenever we have acidosis, does acidosis cause vasodilation or vasoconstriction? Okay, so what I want you to remember is that acidosis causes vasodilation. The reason why there's vasodilation in acidosis is it's a compensatory mechanism of the body to dilute the excess acids. Therefore, whenever you are alkalotic, you become vasoconstricted. So think about that now, that acidosis will cause vasodilation. Now, is rapid deep respirations and paresthesia going to be consistent with this? Well, this would be consistent with respiratory alkalosis. Okay, so whenever you have for example, hyperventilation, you're going to develop respiratory alkalosis, and one of the symptoms of that is going to be circumoral, or the around the mouth paresthesia. Now, so that would be incorrect. slow respirations, nausea, and vomiting. Now, whenever we have respiratory acidosis, usually the body has to compensate by blowing off the carbon dioxide. So it usually would result in a fast respiratory rate. So this would not be correct. Disorientation, remember that in patients who have CO2, there's going to be what is known as CO2 narcosis. So when you trap a lot of CO2, you're going to become confused. You can have vasodilatation and cause headache. And because of the vasodilation, you can have flash face. So this is a possibility. And letter D, Kussmaul's respirations. Kussmaul's respirations is found in DKA, but not necessarily in respiratory acidosis. And muscle twitching could be as a result, again, of decrease in calcium levels. So the correct answer, or the best response over here, is letter C. The reason, again, is because whenever you have acidosis, such as in this case, there's going to be a depressant effect of the acids causing disorientation, and the increased carbon dioxide would cause vasodilation of the cerebral vasculature, causing the headache and also the flushing. All right? Okay. So to classify asthma severity, the doctor will consider how often the patient has signs and symptoms and usually how severe they are. So there are classifications of asthma divided into 4 general categories, and this describes the severity of the asthma. So if a patient is going to have attacks or daytime symptoms at least twice a week, then that's grade 1. And as you go to more symptoms, then it's going to be grade 4. So that's the only utility of this slide, is to tell you that when you hear that the patient has grade 2 asthma, that means to say that they're having not as frequent as one could be, because the range is anywhere from 1 to 4. You certainly are not going to memorize the frequency of their attacks, but just for you to know that there's going to be a grading system, and grade 1 is not going to be severe, but grade 4 is going to be severe. Okay, let's take another question. Very good. All of you got that correctly. The correct response is letter C, a spacer and a thrush. All right, so these are interventions in order to prevent thrush, but in addition to that, we should always recognize that whenever we're using a steroid, in this case, budesonide is a steroid. The ending onide tells us that this is a glucocorticoid or a steroid. And whenever we're using steroids, the risk of infection in the mouth or the oral cavity is going to be increased. Therefore, whenever we have inhalation of these substances like steroids, we're going to use spacers, as well as to instruct the patient to gargle and to rinse their mouth with water after they have used the the steroid inhalation. All right, so what are the current treatments for patients who are having asthma attacks? Well, this would include your short-acting beta agonists, and your short-acting beta agonists would include, for example, your albuterol, and that's the most common. You could also use anticholinergics as well as steroids, leukotriene modifiers, and immunomodulators, meaning to say that we're going to decrease the inflammatory response. And whenever we are giving these medications, note that the bronchodilator has to be given first, and then wait 5 minutes before you even give the steroid. Okay, so that is the rule of thumb whenever you're using two different kinds of drugs that are delivered by your MDI, or a metered dose inhaler. So always wait for 5 minutes. So what are SABAs? SABAs are short-acting beta agonists, and the way in which short-acting beta agonists work is they attach themselves to the beta receptors in the lungs. And so let's just have a quick review of beta receptors. Now, when the adrenal gland releases adrenaline, it circulates in the body and it looks for receptors. And there are two types basically of receptors. And one is what's known as alpha, and the other one is beta receptors. Alpha receptors are abundant in the vascular bed. So they usually would cause constriction of the vascular bed, and therefore they would increase blood pressure. But adrenaline, when it goes to beta receptors, there are two kinds of beta receptors, beta 1 and beta 2. And beta 1 are abundant in the heart, and beta 2 are abundant in the lungs. So it's easy to remember because we have one heart and two lungs. So its action, when it goes into the heart, is going to increase the heart rate, and it also increases the force of contraction. So it's a positive inotropic effect. But this is what we are interested in, your beta 2 agonist. Because when epinephrine enters into beta 2 receptors of the lungs, it results in bronchodilation. So we have drugs that are specifically going to enhance the reception of adrenaline into your lungs, which would therefore cause bronchodilation. Okay, so those are what we call SABAs, for short-acting beta agonists. Well, they're short-acting because they act in less than 5 minutes, but they only last for as much as only 4 hours. So it is used primarily as a rescue medication. It is a short-term relief from sudden, unexpected attacks of asthmatic attacks. Now, there's another one that we're going to be talking about later on, and that's called LABAs, or long-acting beta agonists. Long-acting beta agonists are going to be ones that act within 10 minutes, but they last for longer periods of time, for as much as 12 hours. So LABAs act within 10 minutes, and they last for 12 hours. So this is usually not given alone. It usually is in conjunction or incorporated with steroids. Okay, So SABAs are the first-line medications for acute treatment in patients who have acute asthmatic attacks. So our most common SABAs are going to be your albuterol, which is also known as salbutamol. That's the other name. And the other ones are going to be your metoprolol, levalbuterol, or perbuterol. And all these are going to be delivered by either MDIs or metered dose inhalers or dry powder inhalers. So these are the beta-2 adrenergic agonists, which are SABA. Let's take a look very closely at salmeterol. Salmeterol is going to be a LABA, okay? So the short acting is salbutamol. Don't confuse that. This is salmeterol. Look, the third letter starts with a B, the third letter starts with an M. So this is a short acting, this is SABA, and this is LABA. So salmeterol is a LABA, it's a long-acting beta agonist, along with formoterol, aformoterol, indacaterol, olodaterol. All these are drugs that end with terol, by the way. All beta agonists end with terol. So this is a long-acting beta agonist. And it usually is going to be given with steroids. They're not used alone. Okay, so salmeterol is always used with other medications, other inhaled corticosteroids, in order to control the symptoms of asthma and prevent bronchospasm. Remember that it is not going to be a rescue medication. So when used regularly every day, this decreases the number of attacks and severity of asthmatic attacks. Okay? All right, so as you could see, the onset is going to be 30 minutes. So that's going to be very long. I mean, yeah, and that is why it's not going to be effective for the management of acute attacks. Okay, so the other types of medications are your steroids, and you usually are going to have the suffix zone whenever you have steroids, such as your hydrocortisone, in here mometasone, fluticasone, and the other suffix is onide. So these are inhaled steroids. They're actually useful for management of asthmatic attacks, particularly in children as well as in adults. And usually when they are used, they're going to be of three forms, and they could be an MDI, and the HFA stands for hydrofluoro something. It is the thing that transports the steroids. So that's what's called HFA. And the other one is DPI, and also it could also be given as a nebulizer. DPI is dry powdered inhaler. Hydrofluoro. Okay, so this HFA is not a drug in itself that will have any effect on asthma. It's merely a transporting gas to deliver the steroid. All right. Let's go to another Paul. Okay, so let's take a look at the correct answer here. But before I do that, let's identify what these drugs are all about. Okay, so albuterol, it ends with an erol. So that means to say that this is a beta agonist. Beta agonist. How about ipratropium? So whenever you see tropium, this drug is what's called anticholinergic. So we did not talk about these types of drugs as far as why it's used for the treatment of patients with asthma. So let me just talk about that first, and then we'll go back to that question. The parasympathetic nervous system takes its effect by releasing a hormone, and that hormone is what's called acetylcholine. And acetylcholine, in order to exert its effect in the body, has two types of receptors. And the first receptor is what's called muscarinic receptor. And the other one is going to be nicotinic receptors. Nicotinic receptors are plenty in the central nervous system, so we're not going to talk about this, but we're going to talk about the muscarinic receptors. So when acetylcholine is released in the body, it enters into the muscarinic receptors, and when it enters muscarinic receptors, which are abundant in the lungs, it causes bronchoconstriction. Now, in order to treat patients with asthma, you certainly are not going to want bronchoconstriction, do you? So you want to block this effect. So if you block this effect, it is what is known as an antimuscarinic, or it is also called an anticholinergic from the word acetylcholine. So remember then that if you give an anticholinergic drug, you're going to cause the opposite of bronchoconstriction, and therefore you're going to have bronchodilation. So is that clear? Now, it's opposite what happens with beta agonists. Agonist is a drug that exaggerates the effect of something. So in that particular instance, we're exaggerating the effect of adrenaline on the beta-2 receptors. Over here, we're talking about anticholinergic or antimuscarinic. Antimuscarinic causes bronchodilation because you are blocking the entry of acetylcholine into the muscarinic receptors. Is there any question as far as the two drugs are concerned, the beta agonist and also the anticholinergics or antimuscarinics? Okay, so let's go back to this question then. If we're giving ipratropium bromide or duoneb, duoneb is a combination of albuterol and ipratropium, what is the risk? Okay, so for those of you who have, if you remember pharmacology, we usually do not want to give anticholinergics to these situations. No anticholinergics to glaucoma. What else is the contraindication for the use of anticholinergics? What else do you remember? Okay. Pregnancy, well, not necessarily, but the other one is BPH or benign prostatic hyperplasia. So these two situations are the common contraindications for the use of anticholinergics. So over here, letter A says, I am at increased risk for cataracts if I use this medication. Well, that is not necessarily correct because it is, instead of cataracts, it should be glaucoma. Okay, so remember that glaucoma is contraindicated in anticholinergic drugs. It interacts with some common BP medications. All right, so this might be okay because if you have anticholinergics, you're also going to raise your blood pressure as well as your pulse rate. So it could be a possibility. I can take it hourly as needed for shortness of breath. Hourly. Well, do you give steroids hourly? And the answer to that is no, you do not. Right? And letter D, it is safe to use if I become pregnant. Well, it is going to be always, whenever you are asked about pregnancy and drugs and nursing as well, or breastfeeding, always think about that it probably will be contraindicated. Most of the time, it's going to be contraindicated in patients who are going to be pregnant or nursing or breastfeeding. So this drug actually should not be used during pregnancy unless the benefit outweighs the risk to the fetus. So this letter D is not correct either. Okay. And therefore, the best response here is letter B. So why again letter B? What is the action of anticholinergics on heart rate? It increases the heart rate. So if you increase the heart rate, you're also going to increase cardiac output because cardiac output is equal to heart rate times stroke volume. Okay? So therefore, it would interact with blood pressure medications. It may raise the blood pressure, and therefore it is going to be, of course, contraindicated in patients with hypertension. Okay, so the key word here is acute. So the patient is having an acute asthmatic attack. We need to give something that is a SABA, for example, a short-acting beta agonist. So this would be correct. We know that nonsteroidals are going to increase the incidence of asthma or the risk of asthma. So that would be incorrect. Monoclonal antibodies are going to be laboratory designed to attack a particular antigen. We don't have any monoclonal antibodies for the treatment of asthma. And leukotriene antagonist is one of the mediators that causes asthma. And therefore, if we block them, we reduce asthmatic attacks. But this is going to be prevention rather than the treatment or cure for an asthmatic attack. So the correct answer here is letter B. So what are some of the other measures that we do in order to treat the patient during an asthmatic attack? Well, measures like allaying anxiety is going to be very important. Sometimes we might have to remove the clothing and wash the face and mouth because of the fact that sometimes there might be allergens that is present in their clothes or also in their body. And weight management, weight reduction in obese individuals is going to lead to better control. And then, of course, a monoclonal antibody therapy. These are going to be the ones that have identified allergens. So a skin test is usually done to identify which particular allergen they have that precipitates their asthmatic attack. And then, of course, there are other things like smoking cessation, occupational change, particularly if they're exposed to, like, say, allergens or smoke. And the other one that you see here is the bronchial thermoplasty. This is a new technique that actually delivers thermal energy or heat to the airway wall. And this reduces the narrowing of the airways. This is still a relatively new technique, and this is not widely used at the moment. So I doubt that that will even appear in the Nclex, because usually if it is a novel treatment, usually is not going to be included in the Nclex. Okay, another question. Anybody else? Okay, so let's see what the question is asking us. Which would be most concerning when evaluating the mother's asthma management of her child? Okay, so we're talking to the mother and we're listening to something that is wrong, isn't it? Because it says most concerning. So that means to say that there's something that is not acceptable that the mother is doing. My child uses her inhaler about once or twice a week. Well, this is an infrequent asthmatic attack, so this might not be a bad thing. She usually has to use her rescue inhaler 4 times before improving. This is going to be concerning, because if that is the case, that means to say that the medication that the child is taking is not being effective. And her peak flow reading is usually about 90%. What did we say was the goal?
70.
Yes, it has to be 70%. So this is okay. She sometimes takes breaks in gym class to catch her breath. So sometimes, this is only a few times, right? So that's okay. But this one, letter B, is not good. That means to say that this patient must be brought back to the provider so that the appropriate choice of therapy could be selected. Okay. All right, let's go to another question. Okay, so the question is, if the child comes to the ER with an acute asthmatic attack, what should be the nurse's first priority? Well, remember, there is a hierarchy of our actions. We never intervene until we assess, right? The nursing process starts with assessment. So this is the only assessment that is going to be in here. Assess the airway patency and respiratory status. And it stands to reason. When a patient has an asthmatic attack, the first thing that you should do is to use your stethoscope to determine whether or not you hear breath sounds. If you don't hear breath sounds, then that's going to be a bad sign. So letter C is the correct response for the reason that we have mentioned. Patient teaching is very important to patients who are asthmatic. And so we have to tell them and talk to them about the nature of asthma and the modes of treatment. Also, medications are going to be very important. The difference between rescue medications as well as long-term medications, and also how to use MDIs and nebulization equipment as well. So remember that MDI, metered dose inhaler, is going to require actually coordination. And so in children, it's much better to incorporate the use of spacers along with the MDI. And of course, always make sure that we help the patient identify what the triggers are, as well as teaching them pursed lip breathing. Now, what is the value of pursed lip breathing? Pursed lip breathing actually controls and enhances the expiratory phase. So when you blow like this, you are actually helping the expiratory phase, and therefore pursed lip breathing is going to be appropriate for any respiratory problems. And then, of course, optimal health practices like exercise, fluids, relaxation, and support groups, and if appropriate, smoking cessation. All right, let's go to another poll. Okay, so let's take a look over here. Which medication blocks the function of leukotriene for the treatment of asthma? So again, what is leukotriene? These are inflammatory mediators. So when the body detects a foreign body, they release substances, and part of the substances are leukotriene. Okay, and so salmeterol, Tirol is a beta agonist. Fill-in, of course, is a xanthine, and xanthines work like beta agonists, but actually they're usually given PO and IV. But the use of theophylline is declining. We don't use it as much. And the reason is it has to have a very good level in order to exert its effect. And thiotropium, tropium is going to be an anticholinergic. And montelukast is a leukotriene inhibitor. So this is the correct response. The other drug is saferlukast. Okay. So montelukast and saferlukast are leukotriene inhibitors. Okay, so let's go now to patient education as far as peak flow monitoring is done. Whenever we're talking about peak flow meters, we're talking about a device that measures the highest airflow during a forced expiration. I don't know if you've seen it, but it might look like this. I mean, this is one peak flow meter, but the way in which we use it is going to be the following, that we encourage the patient to do it daily. This is going to be important in order to make sure that we identify early signs of asthma. So when we do the peak flow monitoring, we ask the patient to place the indicator, and the indicator is this one right here. We need to put it all the way to the bottom. The least number in the scale. And then the patient should actually stand or sit upright, and then they take a deep breath, place the meter above the tongue, close the lips around the mouthpiece, and ask the patient to blow as hard as they can. Okay? And we're going to ask the patient not to cough or spit during this time because it's going to cause a false reading. And then, of course, after that, we're going to check the number that is indicated in this scale. So in this particular instance, for example, we have a reading of at least 370, I guess. So it's between 350 and 400. And again, it should be 70% or more of the forced expiratory volume of the patient. So that's usually how we would instruct the patient to do the peak flow meter measurement. How many of you have had the opportunity to see this or use this in your instructions? None? Okay. All right, Chantel Short in PEDS, yeah. This is very useful, actually, and we should always have it in patients with asthma. And by the way, I forgot to tell you, they should always have it, the measurement at least twice, okay? And record the highest. Yes, very good. And record the highest. Okay. Yeah, the reason why they record the highest is because you remember it's their personal best peak flow meter reading. And so they're going to use the highest number. Okay, let's do another poll. Okay, so we're looking at what is the evidence that the patient understands the instruction, isn't it? All right. So it says, will the peak flow meter prevent an asthmatic attack? It does not. It merely tells us what the best expiratory flow of that patient is and if he has an impending asthmatic attack. So letter A is incorrect. I will inhale as hard as I can while using the device. While you remember that what you're measuring is the expiratory flow because the difficulty is in expiration. So letter B is also incorrect. I will use it at the same time and compare my personal best. Well, this is going to be the correct response because that is exactly what the purpose is of measuring your peak flow. And you want to hit the goal of 70% or higher. And letter D is incorrect because he says, I will notify the MD if it is 90% or more of my personal best. While the goal is 70% or more, that means to say that you're doing good. You do not have to notify the doctor if that happens. So the correct response over here is letter C. Okay, very good. So the key here is that we want to exhale hard and fast, isn't it? So letter D is the correct response. Letter A says exhale, but it's slow and steady. That is not going to measure the peak expiratory flow. Okay, so what are some environmental measures to control asthma? Well, there are several things that you can advise the patient, like covering the pillows and mattresses with allergen-proof covers, washing the linen at least once weekly in hot water. This would decrease the possibility of pollen being present in the linen. Keep the dress in a closed closet. This reduces contamination with dust, for example, and that's the reason why we would say that. Vacuum and dust room weekly, and while doing it, they must wear a mask. And if somebody is cleaning, they should be in the outside, particularly if they have a severe dust allergy. And air conditioning is going to be much better compared to having open windows because you decrease the amount of pollen that's going to contaminate you. And then, of course, if they are having air conditioners, they have to change the filter of the air conditioning frequently. And then, of course, avoid both passive as well as active smoking. Now, in particular, when a patient has exercise-induced asthma, this is when the symptoms begin during or after exercise. And usually it is worse after exercise, so after stopping the activity. And some people have reported that they might even have asthmatic attacks as long as 12 hours after the exercise period. So, what are some of the measures, therefore, to prevent exercise-induced asthma? Well, we advise them to warm up before exercising. And then if they have a prescription for SABAs, or short-acting beta agonists, they can administer a dose before exercising. And then, very important, we advise them to breathe through their nose instead of their mouth. And this is to warm the air before it enters the lungs. Remember that cold air can make the smooth muscles constrict, and therefore it should be avoided. And of course, the obvious, avoid exercising when sick with a respiratory illness. Okay, so whenever you have questions that are SATA in Nclex, make sure that you only select the things that you are sure about, because it's scored differently. It's scored right minus wrong. And so the more errors you have, the more deductions you're going to get. So only commit to what you think is right. Okay, so when you want to have to prevent asthma during exercise, should you avoid warming up? And the correct answer to that is no. You certainly should warm up before the exercise. So letter A is incorrect. Letter B, administer a short-acting beta agonist before the exercise. That is a good intervention, isn't it? And then administer a short-acting beta agonist after the exercise. This is not going to prevent it from happening, so that might be incorrect. And avoid exercising during a respiratory illness. This also is going to be correct. So there are only two correct responses over here, and that is letter B and letter D. All right. Whenever you have patients with asthma, we usually are going to tell them to identify or to report their signs as green, yellow, or red. And this is going to be a technique of making sure that they need to know when to ask for help. So if they are in a green zone, and the green zone means to say that there's no coughing, no wheezing, no chest tightness, no difficulty in breathing, and they can have a peak flow of 70%, 80% or more, that means to say that it's okay for them to enjoy the day. But if they are coughing, wheezing, having difficulty in breathing, and have nighttime awakening and a peak flow of 50% to 100%, but with those symptoms, then they have to call the doctor if they are in the yellow zone for more than 24 hours. It is a red zone if they are having the symptoms of difficulty breathing, coughing, wheezing, and trouble walking or talking, not responding to quick relief medications. And if the peak flow is less than 50%, this is an emergency. They must go to the emergency room. It says in here, call your doctor now, but we usually encourage the patients to go to the emergency room. Okay, so green means to say it's okay. Remember that they do not have any symptoms. Their peak flow is going to be okay. Yellow zone means to say they have some symptoms like coughing, wheezing, chest tightness, and their peak flow is 50%. And or more, but they have those symptoms, and then they have nighttime awakening symptoms. That's a yellow zone. They have to call the doctor if this is going to be something that they experience for more than 24 hours. And then, of course, the red zone is when the peak flow is going to be less than 50%. So that's easy to remember. Green is going to be 80% enjoying your day. Yellow zone is when they have symptoms, and then, of course, the symptoms include a peak flow of 50% and nighttime symptoms. And then red zone is going to be less than 50%. Okay, so let's see, which of these require immediate action by the RN and the patient with asthma? And I think I repeated this over and over again because of the fact that this is something that I have experienced. So I used to work in emergency room, and the first time that I had a child and I couldn't hear lung sounds, and I said to the doctor, could you please listen to his lung sounds? And the doctor just got so upset with me. And he says, well, that means to say that this is an emergency. So I never will forget that. When you cannot hear breath sounds, it's not your ears or your stethoscope. That means to say that the patient is severely constricted, and therefore the correct answer here is letter D. Okay, so this is the most serious over here when you cannot hear the lung sounds. Okay, this medication, cromolyn, is Intal. It's an anti-inflammatory. That's the trade name. And one of the things about this is it doesn't smell good, actually. And this actually causes a horrible taste and also a horrible smell. Okay, so reassure the patient that this is a temporary side effect of this medication as far as the smell and the taste is concerned. It could also actually cause sneezing, and sometimes patients will develop watery eyes when they use this nebulization. But these are all temporary side effects of this medication. Okay, so the complication that we're afraid of in asthma is going to be status asthmaticus. This is when this is a life-threatening complication of asthma, wherein the airway obstruction is so severe and unresponsive to usual therapies. And therefore, what it could happen is that the patient could develop respiratory arrest as a result of it. So, what are the signs and symptoms of status asthmaticus? Well, severe bronchospasm, which is unresponsive to the usual treatment with SABA, and usually there's going to be dyspnea. The patient cannot even speak because of severe shortness of breath, and evidence of use of accessory muscles like intercostal muscles, sternocleidomastoid muscles, a respiratory rate above 35, a heart rate above 140, a PEF or peak expiratory flow that is less than 100 liters per minute. That means to say that the patient is severely compromised, and a PCO2 above 50. All these are going to be symptoms of status asthmaticus. So how do we treat that? Well, we treat it with bronchodilators. Usually it's going to be beta-2 agonist, and the other is going to be utilizing your steroids in order to rapidly decrease the inflammation that occurs in status asthmaticus. Okay, so a patient is on salmeterol. So salmeterol is a beta agonist, right? So this is a LABA beta agonist. I can't seem to have my pen work. Yeah. Tirol. So this is a beta-2 agonist. And azone is a steroid. Okay, so I said earlier that we always give beta agonists first, and then wait 5 minutes, and then do the steroids. All right, so let's see. Salmeterol first, wait 5 minutes, then fluticasone. Okay, this is good. fluticasone first, wait 5 minutes, then salmeterol. So this is steroid first. This is wrong. And then 1 minute between, that is incorrect. It should be 5 minutes. And then immediately, again, should be 5 minutes. So the correct answer is letter A. And we'll have our last question of the day. And let's see. Very good. All right. So you remember that. The other name for albuterol, just so you remember, is salbu with a B. Salbutamol, not salmeterol. Salbutamol. Okay. So before we go to the case study, let's go ahead and take a 3-minute break. I just need to go and have a drink. Okay. Let's have a break. Okay, let's go ahead and do the case study. I hope you're back. And let's do it quickly. All right, here's the case study. The nurse cares for a 23-year-old male in the ER who is experiencing acute onset of shortness of breath. So at 11 o'clock, the client reports shortness of breath and chest tightness that is progressively worsened for the past 2 to 3 days. He has a history of seasonal allergies, a non-smoker, and lives at home with his mother, who is a current smoker, denies fever or vomiting, describes feeling fatigue, and has a dry cough at night. All right. So at 11:15, there's audible and expiratory wheezing held throughout. The lung fills bilaterally, increased respiratory rate, capillary refill less than 3 seconds, skin warm to touch, chest wall is symmetrical with no deformity. Client sits upright and leans forward, resting his hands on his knees in tripod position, and speaks only a few words between breaths. Tenderness and palpation of chest wall, trachea midline, no deviation, labs drawn, chest x-ray ordered. Okay, so the vital signs are here. 98, 26, 114 over 78, and 95. So let's see the first question. The nurse assesses the client on admission. Which findings require immediate follow-up? Select all that apply. Okay. Does the shortness of breath need immediate follow-up? I don't have a poll for this, so you either just have to tell me or just chat it if you wish. Yes, okay, good. How about, I agree. I think that would be something that would be of concern. How about chest tightness? That's a sign of dyspnea, right? Okay, good. And if you remember, the respiratory rate is 26. Now, this is fast, isn't it? Okay, so we would do that. How about the dry cough? Wasn't that something that is a symptom of asthma? So we could say, all right, so we can do this and come back later on. How about your audible and expiratory wheezing? Oh, yes. How about the tripod position? Yes, okay. And speaks only a few words? This is worrisome, correct? Now, the blood pressure is not that bad, so that would not be appropriate. And tenderness of the chest wall, that's not an emergency, so we could leave that open. But because this cough is going to be part of all these symptoms of asthma, I think that that should be checked as well. Okay? All right. And question number 2, for each potential finding, click to specify if the finding is a risk factor or not a risk factor for asthma. Is family history a risk factor? Yes, okay. And how about allergies? Yes, definitely. And beta blockers? Yes. What are the other medications? Aspirin and non-steroidals, right? Okay. And, oh, sorry about that. All right. Edema, is this a risk factor? No. Okay, so it's not a risk factor. How about viral infections? Yes, very good. Smoking? Yes. Overweight? Yeah, you remember one of the interventions that we said was to decrease weight? Right. So this is going to be a risk factor. And diabetes is not a risk factor. So that would be the way in which you would answer this. Okay. So now you have the lab reports over here. This is the thing that is new. Complete the sentence from the list of drop-down options. The nurse should recognize that the client is most likely experiencing pneumonia, pulmonary edema, acute asthma attack, or pneumothorax. What is your diagnosis? Acute asthma. What is your evidence? Of all these listed here, what is the evidence? It would be the wheezing. It's Because shortness of breath, you can have it in any other respiratory condition, but because of the narrowing of the airways, you're going to have wheezing. Okay? All right. And now we have this particular laboratories. It will be shown again later on. Which of the following interventions should the nurse anticipate, including in the plan of care? Select all that apply. Okay. Do you want to give oxygen for a pulse oximetry that's less than 93%? Yes or no? Yes. Okay. How about albuterol? What is albuterol? It's a bronchodilator. So yes. Place the client in a supine position. No. Okay, good. Administer low-dose aspirin. You would kill the patient. All right, no. Administer labetalol. Alol is going to be a beta blocker. So do we want that? No. Okay. And administer ibuprofen. No, that's a non-steroidal as well. Raise the head of the bed. Yes. And administer solumedrol, IV SAP. Medrol is going to be a steroid, right? So you remember we want to decrease inflammation. You remember I said on that slide before we had to, for Asthmaticus, we have to give steroids. So this would be okay. And oral fluids by mouth, yes or no? Okay, so Lindsay and others, whenever a patient is short of breath, whenever a patient has respiratory problems, they need increased fluids. But when they're short of breath, you must keep them NPO because there's an increased risk of aspiration. So this letter I is a no-no. Okay? So it's a no-no. So that would not be a correct response. All right, so here are the orders, and we're going to see the orders again. And so the question now is, the nurse reviews the physician's orders and considers needed teaching. So of all these, what are you going to do? Should you instruct the client on peak flow meter use immediately within the hour or before the end of the shift? What is the principle about teaching? You don't teach a patient who is in distress. That is the principle, because they will never pay attention. If you cannot catch your breath, you're not going to follow instructions. So this is something that you could do at the end of the shift. So remember the principle that in a patient who is in distress, they're not going to have an attention span, and therefore you're not going to do teaching. Okay. How about administer 2 liters of oxygen by nasal cannula? Should we do it immediately within the hour or before the end of the shift? Immediately. Okay, very good. How about administer solumedrol? Yes, immediately. Administer albuterol and ipratropium. Again, these are kinds of bronchodilators. Yes, immediately. Instruct on pursed lip breathing. Yeah, well, very good. You could do it within the hour because it's now going to be less acute, and therefore you could just coach them as far as, okay, let's go ahead and slow down your breathing. by pursing your lip and breathing through your lips. So that is something that you could do within the hour. All right. Instruct client on home medications. All right, the end of the shift. Remember the principle, you never teach a patient when they're in acute distress. And apply continuous pulse oximeter. Immediately, very good. Okay, great. And now we have the nurse assesses the client at 13:30, implementing the physician's orders. The nurse determines the client's status is. So this is at 13:30. Nebulizer treatments and Solu-Medrol given, denies shortness of breath or difficulty breathing. Lung sounds are improving. Client can speak in full sentences and tolerates the activity of daily living well. No reports of fatigue. So what should we do? Is the client improving, deteriorating, or unchanged? Okay, improving. And the nurse should now, so should you prepare the client for discharge, resume the breathing treatment, or continue to monitor the client's breathing? Okay, so all the findings are all now normal. So this means to say that the patient is now ready for discharge because the shortness of breath is resolved and the oxygen level right here, you see this is now on room air. The patient is now what do you call that, stable, and therefore the patient can now go home. So the correct answer here is letter A. Okay. So I hope that you have learned something today about asthma. We continue with our discussion with CHF, I think, tomorrow. So I look forward to seeing you again. And I thank you for being back. And hopefully that I am helping you. Okay. Thank you, Fabiola, Lindsay, and Chantel. I will see you again tomorrow. So if you have any questions, please go ahead and type in the question or ask me now.
Thank you.
I have a question about the, because I keep getting mixed up with the albuterol, and so you're saying that while they're having an acute exacerbation, we're supposed to give that medication. I forgot the name.
Yeah, short-acting beta agonist, and the short-acting beta agonist. Let me just.
There was a question, and you said we should give it, and I was thinking short term, so I wouldn't.
Yeah.
Give the corticosteroid.
Salbutamol you give. This is the same as albuterol.
Oh.
And the other one is salmeterol. That's the one that you're talking about. Salmeterol is LABA, long-acting beta agonist. It will not help for acute symptoms. This is a SABA, okay? That was the question I know that you're referring to. So you give salbutamol, but not salmeterol. Salmeterol will work to prevent asthmatic attack. All right. Okay. So the way that you remember that is this B is a letter that comes before M. So salbutamol, that's the only way that I remember it, is short acting. The M is long acting.
Okay. And the one where you put the double with the albuterol and
okay, with the steroid. Okay, so if you have albuterol with steroid plus steroid, and that is called Duoneb.
Yeah.
So you would give the albuterol first, then 5 minutes later, you give the steroid.
So in this case, it is okay. So that's where I was getting confused.
Yeah. Mhm.
Because I'm thinking, okay, it's salbutamol, so I'm not gonna give a steroid. That's what I was thinking. But you're saying in this case, albuterol and the steroid is okay.
Yeah, because they're already joined. There are two drugs in one.
Oh,
That's why it's
that's
called
what- okay.
duo neb. Duo means two. So
Yeah.
this is a combination drug. So they're already mixed together.
Oh, now it makes sense. That's
It
why,
makes
because I'm like,
sense.
no, it's short term. Why am I giving a steroid? But now
Yeah,
that you're
right.
saying, no,
Yeah.
okay. So I'm
Be-
now clear.
Yeah, because the albuterol is short acting, and
Yes.
the steroid is going to be an anti-inflammatory. Okay.
Okay. Thank you.
You're
Steroid.
welcome. All right.
All right.
So I'll see you all. Have a good evening and thank you so much. All right.
Thank you.
You're welcome. Bye-bye.